dear colleagues, speakers, panelists, and guest audience, welcome to our monthly webinar here at EMFNet. And I wish you a fruitful discussion that as for today, we are discussing a painful topic. And as I'm sure all of us we are following the situation in Sudan approaching its thousandth day, exactly 955 days of continuous violence, and our people in Sudan are still suffering death, illness, malnutrition, and displacement, not to mention the psychological consequences of this war. And the recent escalation of violence and attacks on civilians and health workers, as documented in Al-Fashir, North Darfur, in the last few weeks, and many other areas actually, carries serious warning signals of the humanitarian situation in the country. Despite the appreciated efforts that are made by the government and non-government agencies and partners, but still the gap is huge and the needs are many. In this light, EMFNet convening this webinar to bring together voices from Sudan, from the region and beyond, to listen to our colleagues who have the first-hand experience on the ground, as well as the experts with similar conditions, whether in Sudan or outside Sudan, to reflect on the country's urgent needs and gaps, discuss relevant relief and recovery models, and map practical pathway for coordinated response. To this end, we have the objectives of this webinar are to discuss the current public health status in Sudan, identifying key challenges, priorities, and opportunities for response and recovery, and to highlight the roles and responsibilities of the international community and partners in relief operations and meeting humanitarian needs. And finally, to come up with practical recommendations and actions that can foster collaboration between national authorities, humanitarian organizations, and partners to mobilize resources for the response and recovery operations. So to start this webinar, I would like to first welcome my friend and colleague, Dr. Muntasir Elhassan. And Dr. Muntasir is the Director General of Health Emergencies and Epidemic Control in Sudan, and who oversees also Sudan FETP, preparedness, response, IHR, One Health, and many other departments under his supervision. Dr. Muntasir has an MBBS and MSc in Epidemiology and Biostatistics, and he has many published scientific papers. He has navigated the effort of the Ministry of Health response under the FEEC department throughout the wartime. So I think Dr. Muntasir is the most suitable person to tell us about the current situation in Sudan, what is going on, what are the critical needs, and what are the efforts being done by the Ministry of Health. So welcome, Dr. Muntasir, and we have like 15 minutes to share with us your presentation. Welcome, Dr. Muntasir.
Thank you very much. Thanks. Thank you, Dr. Haytham. Thank you very much, all of you, for giving me EMFNet, for giving me this opportunity. I will present the current situation and our future plan. It will be good, Dr. Haitham, if from the organizer from your side
Sure.
share the presentation.
Sure. Yes, please, Mira. Yes.
Okay. As you know, all of us, that this conflict started from the mid of April 2023. Militia with against the RSF, and most of the states in the country have been affected. This it also affected, unfortunately, the health sectors, like key infrastructures of the institutes, hospitals, BHCs, supply warehouses, all of them or in the affected area, in the conflict area, destroyed and looted. Also, this affect the financial by financial loss that estimated to be billions. The systematic target of the militia that brought destruction for essential health infrastructure, and also including the National Medical Supply Fund, pharmaceutical industries, hospitals, BHCs, and even the specialized medical centers across the nation, in particularly the affected area. Next, please. Yes. Impact of the health workers also. Health workers have faced violence, intimidation, and also forced displacement. This resulted in, unfortunately, drainage of brain of those subspecialties who moved abroad, and it is very difficult for us and for this time to retain them. Next. This conflict affected the health facilities. Almost more than 120 hospitals have damaged totally or partially. In addition, that the workforce, in particularly in these affected states, almost more than 13 states affected this time. Up to date, in addition to the forced displacement of population of more than 12 million internally, and even externally, we have refugees of more than 2 million. Next. This is, for example, we have almost more than 7,000 health facilities. More than 33% of these health facilities have been affected, and this is by state. Like, for example, the functional rural hospital by now is 1886, and those that affected almost 380 plus. In addition to BHCs and also the effect in BHCs and BHUs. Almost more than 2,500 BHCs affected, and also primary health units, more than 2,300 have been affected. For this current situation, from the start, the Ministry of Health planned for 3 phases, including the first is a response phase that supposed to be in 2023, but even now moved up to this year. We are still in a response phase, although we started the recovery in some of the states, like those now with the government responsibility, like Khartoum and Jazeera State. This a response phase, we put impact assessment, conducted impact assessment, restore the basic service, and this is what they plan to provide the essential health services, the BHCs, and also secondary, also address the epidemics and rebuild infrastructure, establishment of decentralized governance, like supplies, like referral centers, like also specialized centers. For the years from year 2 to year 5, the plan was to reform and reconstruct. And from year 6 to year 10, to develop and sustain the health system. We will go further in the next, please, Dr. Haitham. These are the three phases, and what I mentioned: the response phase, reform and reconstruction phase, and development and sustainability phase, that we are planning to improve the health system through. We do not want to rebuild, we want to improve and improve the health system in general through governance, leadership, and also construction of advanced health facilities and warehouses, and decentralized warehouses, and also the health system. Next. For the health response framework that we mentioned, the first phase, we have 5 priorities, 5 pillars, that including essential medicine supply, emergency health services, epidemics control, maternal and child health, BHCs, and maternal availing BHCs and maternal health, in addition to governance and leadership. With these 5 pillars of the strategy, response strategy, we moved in the response phase, and we are still in this response phase with a partially improvement in some of the states. We move to recovery. Next, please. The urgent humanitarian need and also the results from this conflict, due to the immediate priorities were to restore basic health services, as I mentioned, address and contain epidemics, support vulnerable population like the IDPs, and also those including children, women, and elderly, and rebuilding essential infrastructure and leadership and governance through coordination between the government within and also between government and partners. The environmental threats that affected by getting outbreaks like pollution and contamination from conflict, compromised water and sanitation that resulted in outbreak of cholera in almost the 18 states, and also outbreak of acute jaundice syndrome, hepatitis E, in particular in Kassala and Jazeera, and also sporadic cases reported from other states. Increased disease transmission risk, like the vector-borne diseases, like dengue fever and malaria, that are now in epidemic phase during this rainy season. Also limited access to clean facilities that affected also the facilities through acquired transmission, infectious disease transmission. Next. The vision for this strategy, 10-year strategy, including comprehensive framework guides the transformation of Sudan's health system, connected immediate response with long-term sustainability and development. The integrated approach ensures that every intervention builds towards our vision. resilient, equitable, and sustainable health system for all Sudanese. This vision, next. This vision, as mentioned by His Excellency, the Minister of Health, the guiding vision is to ensure equitable and sustainable health services to the people of Sudan through a health system that is holistic, resilient, effective, and agile. Our focus is on moving from response to recovery, reconstruction, and development. Adopting a health for all approach by engaging all stakeholders and also the government and community members. Next. This is a vision framework that we built. We will consider that in our coming also slides. Next, please. Equitable and sustainable health services for all. We want to reach that by holistic, resilient, effective, and agile, as I mentioned, health system that to be equitable, sustainable, and resilient. Next. It is also to be a community-centered approach that to engage the community, to engage the stakeholders, and also to aware them about the health services, to include them in from the start, from the preparedness, response, and recovery phases. This included partnership, community engagement, and reliable infrastructure. Next. The strategic pillars for transformation that include and based on the strong leadership and governance, robust health workforce, and adequate health finance. For the strong leadership, it is a clear decision-making, accountability mechanism, and coordination across government, private sectors, and community stakeholders. All the three areas, the government, private sectors, and community stakeholders, in addition to the UN and INGOs and NGOs. Robust health workforce, we want to reach with trained, well-trained staff, equitable distributed, all through the country, an appropriate compensated workforce, ensuring safety, motivation, and adaptability. Adequate health finance, this is for sustainable financing resource, and flexible funding for routine and emergency operations. Universal health coverage mechanism to reduce out-of-pocket costs. Next. The strategic shifts, including the governance, shifting in governance, the transformation will give us how we will lead, decide, and deliver healthcare through policy approach, stakeholder engagement, decision-making, and accountability. For the policy approach, we want to move from top-down to bottom-up, from fragmented ministerial policy to integrated national health policies. Stakeholder engagement, we want to move from limited stakeholder involvement to all of government and all of society approach. Decision-making, traditional approach, we want to move from the traditional approach to data-driven decisions and evidence-based decision. Accountability, from poor accountability to clear role and transparency, enforce standard, strong regularity mechanisms. Next. The two pillars for the strategic shift, including the financing, and for the finance, we want to build a sustainable and equitable system that with adequate investment, clear roles, and financial protection, in addition to unified financing and results-based purchasing. We want to move from insufficient funding to adequate funding and efficiency of public expenditure on health. The clear role from in this thing, separation of role to clear distinction between organizers, purchasers, and provider of health services. Financial protection from out-of-pocket financial healthcare to prepaid financial health system with protection of marginalized and vulnerable populations. Unified financing from fragmented finance to one unified finance and risk pool, and also result-based purchasing. Next. For the workforce, we want to move for the workforce reconstruction skill mixed to have health cadre with multidisciplinary workforce planning. Through multidisciplinary workforce planning, we want mixed of skills personnel, in addition to integrated policies, holistic human resource strategies across actors, evidence-based, coordinated governance, and also valued asset for the workforce as stakeholders and shareholders. Next. This is our plan, and this is also the current situation that we think the damage is far the available resources is far from what we are in need really. So there is a significant shortage in and limitation in all the resources, human resource, financial resource, and equipments that require comprehensive and accountability and contribution from all, from the local, from the government, and also from stakeholders to bridge the gap in this situation. This is from my side. Over to you, Dr. Haytham.
Thank you, Dr. Muntasir, for the clear and informative presentation. Actually, I'm quite reassured because I was expecting only the impacts and the negative consequences of the war, but seeing that the Ministry of Health already started planning and looking forward for the recovery and all that might be quite assuring. However, to complement this overview about the situation in Sudan, I want to also listen to the other side of the service provision, which is non-governmental agencies. And I think I'm privileged to have a representative of one of the most, I claim, one of the most active organizations on the ground, SAPA, for those who don't know SAPA, Sudanese American Physician Association. And I'm really pleased today to have with us Dr. Anmar Homeida. He's the Executive Director of the Sudanese American Physician Association. He leads large-scale emergency health operations across conflict-affected areas in Sudan. Dr. Anmar is a physician with and public health strategist with experience in emergency health services and humanitarian response. He's a medical doctor with an MPH, MSc from Harvard Medical School, and now he's pursuing his PhD at the New York University. So, Dr. Anmar, after we listened to what Dr. Muntasir presented, how do you see the situation on the ground as an NGO? What are the challenges that face your organization and maybe other organizations, and how you could manage running your services in this um, context. Please, Dr. Anmar.
Thank you so much, Dr. Haytham, for having us, and it's a great pleasure to be part of this distinguished panelist. Honestly speaking, it's kind of an important topic to discuss right now with the different fragmentation of health system, unfortunately forced fragmentation we're currently seeing. Adding to that also the aspects of the near collapse health service delivery, which are the cornerstone of any lifeline you want to actually secure for our people in Sudan. As just clearly stated by Dr. Muntasir, the crisis of Sudan is unprecedented one. Right now, based on the different UN agencies, including the UN airshows through the Humanitarian Need Overview, more than 30 million of the Sudanese population are currently in need. You are talking about 2/3 of the population of Sudan are continuously facing different basic health services, infrastructure disruptions, whether it was health or other sectors, which is directly interlinked to health. And this is what I also wanted to allude into as part of our unfortunate push from our side to jump at. The first crisis that we actually dealt with is actually the aspects of acute hunger and malnutrition, and which is unfortunately extensively neglected, let's say from the holistic look for health service delivery, which is unfortunately also increasing the burden on the different health services we are providing, including the unprecedented outbreaks that we are currently facing as well, the different overlap of outbreaks, as just clearly stated also by Dr. Muntasir, is quite heinous for Sudanese people to deal with. Most of the burden is actually coming to the local communities, and this is where we have the strong ties with. The nature of SAPA is locally led, but globally supported or globally empowered, as we always love to say, which means most of the aspects of the needs assessment, aspects of even strategizing our interventions are actually coming from the local communities on the ground. And those are the most two important elements of the different information that we are getting: the acute malnutrition and hunger, and the overlap of epidemics and outbreaks. And the last element is actually the unseen burden linked to the trauma, the aspects of poor obstetric care, maternity health, the aspects of the unprecedented also cases of NCDs that are actually not properly counted. You can always see them in overcrowded areas or areas condensed with IDPs all over the country. So with that note, this is how we tried the best possible to strategize the intervention that we are supporting on the ground in a way that could, first of all, responding to the immediate demands that has been highlighted by the local community to filter, those demands in a way that could help us respond to the immediate mortality risk. Managing the malnutrition was a core priority for us. Adding to that also, specifying, the different intervention that could help, the aspects of managing trauma, the aspects of managing sepsis, other aspects linked to the obstetric care. The second element was actually the epidemic control to support the best possible, the community-based outbreaks preparedness and response, with also providing the basic preventive interventions, including the aspects of provision of sanitation, water, and other aspects linked to the hygiene, specifically in the nearly very condensed areas of IDPs, adding to that also the newly arrived IDPs. And we are trying the best possible to give the country a holistic lens as well. And this is also very important for us to be sensitive against. So we are trying the best possible to utilize the limited resources that we have in a way that could respond to the different demands that we are seeing in Darfur, we are seeing in Khartoum, we are seeing in western part of Sudan or the northern part of Sudan as well, throughout this disastrous war. And the last element that I just wanted also to maybe allude into is the aspects of always like maintaining the primary healthcare services as a lifeline. Wherever like people have been displaced, we are trying the best possible to restore the primary care services in a way that, first of all, give them like a protective shield for the communities recently displaced, providing like some sort of initial screening that could predict, any kind of either infectious diseases or malnutrition cases that could be captured through like the different influx of IDPs we are facing in the different regions in Sudan. The recent was in Al-Fashir. People are coming to Tawila. We try the best possible to distribute like different entry points-based clinics in a way that, first of all, give the proper screening for the people who recently arrived, and to that also support them with the needed referral services as well, as much as possible in coordination with other humanitarian actors on the ground. We are trying the best possible also to align, the local efforts as much as we can. The resources are limited, the needs are like scarce. So like coordination, it was like a core date for us to try the best possible to invest in. And we are trying also to be like, the connection dot between the humanitarian agencies, UN agencies, local actors on the ground, the Ministry of Health and other like governmental actors as well. And also the de facto actors, whether it was like local initiatives or like other community groups and members. So it's a huge burden to jump at, but are trying the best possible to manage, what we have at hand in a way that could support or boost, the health system resilience as much as we can. Thank you.
Thank you, Dr. Anmar. And I visited your office in Sudan 2 months ago, and I have witnessed the huge efforts that your staff are doing on the ground. And I agree on the importance of coordination. You mentioned the community-based model, and also the scarcity of resources. Those are the points that I would like to elaborate more in my next question to Dr. Naima. And Dr. Naima, I think all of us know Dr. Naima. Dr. Naima Qasir is a global health sustainable development expert with more than 40 years of leadership across complex humanitarian development and health system settings. She served as a WHO representative in Sudan, as well as other countries in the region. And she played a pivotal role in strengthening health systems, responding to major epidemics, and advancing One Health. She is known of her strong stand for the gender equity, the community approach, women, youth, and other topics during her service. And so, Dr. Naima, welcome to this webinar. And I would like to listen to your reflections on the governance and coordination gaps in Sudan, which may be similar to other situations. Also, if you can reflect on the community initiatives and the lessons learned from global experiences as well. So, Dr. Naima, the floor is yours. Welcome.
Well, good evening and good morning, wherever you are. I would like to, first of all, thank you, Infinite, and thank you, Dr. Haytham, for reaching out, and thank Dr. Muntasir and Dr. Anmar for making my life easier. Dr. Muntasir paved the way, and Dr. Anmar put one of my soft spot, which is the community. If you look in my title, I added "and peace." Actually, I served in Iraq in 2003, and who are young, were not born yet, please go and read. It was at a time which was the first country others interfered and came in for democracy, and we had a lot of big situation. The way I'm going to address the questions on community and at the same time governance with the focus on equity lens, already mentioned, with the focus on engagement, inclusiveness, and at the same time, respect and dignity. This is what actually guided my work in Iraq and then throughout, with care and compassion. The reason I put peace, because that's where I learned from Iraq, that we cannot do emergency, humanitarian, rehabilitation, recovery, development towards peace. And that's why I put it in the title. And that's why I wanted to really focus on this. The title given to us was Survival to Recovery, and that matters. Always countries in conflict. I have served most of the time in countries of conflict and complex emergencies, and most of the mentions were made. I think I am controlling, right? Yes. Now, this is where we are talking about what...
Dr. Naif, if you can put your slides on presentation mode.
Yes, I know that something was missing. Now, as a strategic roadmap on trust, building on trust. Trust is the essence. Dr. Anmar said it in one way or another. Dr. Muntasir said it also. And if we do not believe in it, and people who are working with us, we are going to actually invest a lot with low return. Building human dignity is one of the things that I keep always in mind. Sudan is very close to my heart. I served there for 5.5 years. I witnessed the revolution. On the 3rd of June, with the setups, I had to be actually addressing it. But later, and since for the last 2 years, has been really more painful in terms of seeing the frequency of the people being displaced, the same family, the same individual being displaced. And how are we going to address this? So no envy to the Minister of Health and the government and Dr. Muntasir and what you are doing. But one message I want to give, we can use the health system framework, which I come from after 26 years. But when we come to the situation on the context, we need to think differently. And definitely, as said, we need to put the resilient seeds in order to believe it, with the core of community and the people locality on the ground. In I'm talking about unity and the health in all policies. I don't know what I did, but health in all policies, I will explain it more later. And when we talk about health system recovery, the cornerstone is the primary healthcare, not only the center, but from wider sense. And we will address it. When we talk about healthcare workforce, we do not mean physicians and nurses, and it could be community health workers and others. And already I mentioned care and compassion. I will not dwell on this because numbers were given by both. And one thing that I would say, the collapse of the health systems, even the best developed health systems during COVID-19 showed the collapse. So it can happen if we do not have the people around us. Again, I will not dwell on this, but there was an issue on famine. I'm a believer that we need to start from local, including showing them how to grow their crops and not wait to be given. That's the domestic resources. Again, I will go to the immediate lessons learned. I always was looking at the Rwanda case very early on in my life, and South Africa. These are the two countries affected me. South Africa with the truce, and Rwanda with the way they did the recovery. And if we look across South Africa, Rwanda, Afghanistan, Iraq, and at the same time South Sudan and Sudan, community has been the core. I am a product that we were taught about Al Jazeera project in Sudan, never visited Sudan, but in our education, it was at the heart. And when I visited, I could see that local communities have been empowered. So community and community health workers are critical. Trust is across. But when I said health in all policies and primary healthcare elements from the broader aspect, water, sanitation are critical. Not to wait to see the blood to give the first aid. We know dengue fever will be there. We know malaria is going to be there. How can we have the people with us and try to bring with us, even if they are displaced? What are the priorities? I always talk about cultural sensitivity. Again, as I said, I have learned it from Iraq, and then learned it more in Sudan because I saw it there. The women leadership and the youth. We are saying women, but in the reality, we are still looking at a medical model mentality on how should be happening. I want to say this specifically. It is time to shift. Essential services, what does mean to us and what does mean to communities? It might be water. That's what I faced, reality. It might be a piece of bread. It might not be for a medicine. Usually they put medicine the latest. But this is something where the communities can come up. Flexible contracting, and Dr. Anmar alluded to it, is from the local organization. And I like when you say it local to global. Actually, Dr. Anmar, I immediately put a note. Are we going to have other NGOs who are supporting globally to invest locally and follow that model and just give the support? Can we invest to do local production of water somehow? Can we invest to do the food, nutrition, and Sudan is rich in this. Peace is the core. Health as a bridge for peace is actually guiding us, and it should be used more. Today, I did put digitalization and AI, and a lot is going to be there. There was a discussion about governance and coordination, and we are going to speak more later in the second session. What are the gaps and what are the challenges and how the inclusive solutions can bring? We know about fragmented authorities. We know about different political, I don't know whether to call it political or people controlling one way or another. And how are we going to bring the authorities to be thinking differently? Communication breakdown is not only the reporting relationship, it's at the local level, between parents, between the local leaders. It's how can we gain their trust so they can actually work with us and among us and with them. Trust deficit is one of the key things happening in all our regions, actually more than one country in our region. How can we strengthen that? That, from my basic experience, was to have dialogues from smaller groups to little bit wider groups. And Sudanese are excellent in the dialogues, but maybe we need to shift the thinking on how dialogues should be generated. Already it was mentioned about local capacities limitation, but I believe they are strong. It's just to give them the trust to take it on. So inclusive solutions for authorities, health in all policies from انتوا شنو تقولون الجيرة من الحي يعني من الأسر السبعة 8 أسر هم they can do it. So we are talking about very local. And CSOs can be, by the way, even the religious. I might not be religious, but I will utilize them. And I have been very effective in this under the belief that we need to protect lives. How can we do it? And working with the different fighting parties. Inclusive coordination mechanism, what do we mean? It is not sitting in a high hotel. It could be under the tree. And again, I learned it from Sudan very early on in my professional life, where you can dialogue and communicate. Health worker protection by giving them some support incentives. And health workers today who were displaced, they demonstrated. The ones who went to Jazeera, the ones from Kassala, Gadara, they kept moving, but they kept bringing communities. And we have the definitely prevention, definitely promotion, and curative care is now taking a lot of our attention, but we need to balance between this. Local capacities, and already was mentioned. I'm going to the next slide. Did I go to the next slide for you? High impact intervention. If anybody is interested, you can go and search. You will find the maternal child health was mentioned, but I did put mental health and what I call psychological first aid. In my early life, very early life, whether in Libya or Palestine or Iraq, Yemen, this mental psychosocial has been, and definitely Sudan, have been critical. One experience from Sudan that I learned, preparedness, and it was a success. When during the movement and the revolution in 2019, we trained hundreds, and I say we because there was a large team, including with Ministry of Health, Dr. Muntasir might remember, first aid, CPR, basics on how to keep cleanliness, hygiene, all this in preparation. Something happens, will be people ready. And I remember we gave the youth a bag with full of first aid. I'm almost finishing. Okay, I'm hearing my voice back.
Anmar, if you can please mute.
Yeah. Community health networks, locals, even if they move in Sudanese are very good, and this is an essence that we need to how can they can be linked. They have a vast network, women-led, at the same time youth, so we can utilize them. I already mentioned about healthcare workers, but their safety is critical. And for me, I am some person who says We are there to serve. We are not there to be actually sitting in our comfortable places. Now, community initiatives, we know women-led initiatives. In Sudan, you have very much empowered women. When they are displaced, they still know how to find their resources. One of the success that can be started from now, preparedness of the youth, and looking at their angle of psychosocial first aid, giving them the tools. Every youth, regardless of what is their background. Culture and outreach are critical. I have utilized in Sudan successfully the issues of how through poetry, through play, through music, this has brought people together. In terms of existing community structures, who is actually the leader in that neighborhood who can actually bring the change? Who can be building the trust? And I think we can easily identify them. If you realize, I'm not going and talking about people who are in the health structure. I'm not talking about people who are having our comfort zone, that they are in the system. How can we shake it and go after the system? However, I am a believer in the integration. Dr. Anmar said about the bringing all the entities together to align the resources. This is, we used to do it through the health cluster, but it's still same concepts. And that was one of the successes in Iraq, that we brought clusters together, the water, sanitation, nutrition, and we were able to actually build on each other to reduce cholera, to reduce schistosomiasis, to reduce, I'm not talking about Iraq. And I brought that experience even to Sudan early on. However, I cannot say I'm expert today because situation, context has changed. The co-design of community appropriate solutions. I mean the regular integration in the system, not a follower. And I think Dr. Muntasir said it already. Around the table, they might not be educated as we are educated, quote unquote, but they are educated. I mean in terms of the degrees. So this will bring them to the governance center under system integration. And at the same time, transparency. If we do not have the money, we say we do not have the money. If we have $1, if we say equity, engage them on how should be distributed. Not easy task. I have been there and I know what it means. I have been there and I empathize when my colleagues are actually in this situation. And monitoring system, I'm sure Salem is speaking later. Let them be your eye. Salem remembers, I say, the community is my eye. They will tell me what's happening. It's not me saying I am doing the best. They will tell us. Now, what are our call for action? The answers is not everything under the scan. If you realize I did not go through the protocol of the health system framework, still utilize the same thing. Rebuilding health systems with care and compassion needs the trust and culturally appropriate. In terms of applying the lessons from each one of them, we are having a lot. From South Africa, I always talk about the truth. From Rwanda, I talk how they use the technology with the resources that they had to deliver the medicine. From Iraq, health in all policies, and they managed to bring a lot of things to do. Bridging the governance gap is something, a belief. If you believe, you can make it. And we did it in Sudan. We did it, but it did not sustain. Dr. Muntasir invested 2 slides on financing. We need to shift financing waiting from outside. It's not working. Still, it is linked to political decision. Today, they stop, it is stopped. Nothing comes. So we need to have alternatives on how we are doing to do it. High priority impacts, Victor already mentioned about maternal child health, the investment of $1, the return is $10. The same with vaccination. I always use for polio $1, $20 return, and the same investment in healthcare workers. Just the care of giving them some tools will bring their investment back and return back. So formalizing women and youth-led initiatives. Inshallah, Dr. Haytham, your next session on emergency rehabilitation, humanitarian and development and peace, you will have the youth-led discussion and solutions to be bringing to us. What do we need? We are having a recovery. It's a must. Survival is a continuous, but then it is must acting now with all reducing the loss of lives. I think we should focus, and Dr. Anmar, you are in a better position to make sure that we prevent the dengue. We know dengue is coming. Every year dengue is coming. Every year cholera is coming. What are we doing to prepare it and prepare the communities who are displaced to make it less. It will happen, but to make less and at the same time save lives more. Thank you very much.
Thank you. Thank you so much, Dr. Naima. I think what you just did is you blended knowledge, experience with wisdom. I really liked your presentation and the way you conveyed your messages, very strong messages. Thank you for that. And just to have the opinion also from different perspective, we have with us today Dr. Maysoon Al-Bukhari, who is a senior health expert with experience in leading health initiative across MENA region, Latin America, and the Caribbean, Asia Pacific, and Africa. Maysoon is trained as medical doctor in health policy. She specializes in co-creating resilient and sustainable health situations or solutions with governments, partners, and communities. She's pursuing her PhD in global health systems resilience at the University of Geneva, and her work focuses on risk management, equity, and strengthening health system to deliver lasting impact in fragile and high-risk settings. I have the opportunity to read, Maysoon, your recently published article about measuring what matters, key indicators for performance and resilience in fragile and low-income context. But my question to you, Dr. Maysoon, I know how close you are following the situation there in Sudan. How do you see the direct and the indirect impact of war, and how we can minimize or reduce this impact following the model that you described in your publication? Yes, Dr. Maysoon.
شكرا جزيلا دكتور هيثم، وشكرا دكتورة نعيمة، دكتور أنمار، ودكتور منتصر. definitely my senior و definitely my expert مع the خبرات that is here. I was saying definitely I'm not senior and definitely I'm not expert with the colleagues with whom I'm privileged to share the space. I usually start by saying we are trying to understand the symptoms and the underlying pathology and the social determinants before we can prescribe and reflect on an effective solution and on health system resilience in fragile context. And as Dr. Naima had said, there are 2 billion individuals living in fragile context, living in a situation that's similar to what we are living through in Sudan. And if we take the classification of OECD on fragile context. Also, before starting and responding to your question, I think before we discuss the impact of war, it's important to remember that we had issues before the war. The OSHA 2022 report said there were 5.5 million internally displaced and 15.8 million were in need of humanitarian assistance. That's before the war in April. Before the war, our universal health coverage index was 44. In 2017, a year that people cite that was relatively a stable year. So we had issues to start with. On the direct and indirect impact of war, there are multiple researches now published recently on the direct and indirect impact of war. The key message is that the global conflict events have nearly doubled in the last 5 years. Yeah, in 2020, it was like 100,000, not 100 only. And in 2025, it's almost 200,000. There is a monitor for that. An armed conflict is a critical determinant of the population health. Yeah, we have the direct impact and we have the indirect impact. WHO highlights that approximately 90% of the conflict-related casualties since the World War II, it happened to civilians. It didn't happen among the army. And most of that is associated with the indirect impact of war. The direct impact is the explosive weapons, the landmines, and now with the drones, things are getting worse. All of us have read the recent research from Yale University Humanitarian Research Lab, and thanks SAPA for acknowledging their efforts. And they are estimating the range from 20,000 to 150,000. But the lab executive director said, we can't responsibly give a number. Many who would do the counting are dead or displaced. The attacks on healthcare, there are multiple sites that are monitoring that. That's also really painful. On the indirect impact, I think Dr. Naima and Dr. Anmar had elaborated on that. The war disrupts the food production and then the malnutrition, the damage to water and sanitation system and the overcrowding in the camps, limited healthcare access and the disease outbreak, cholera and measles, the non-communicable diseases, the chronic conditions, the increased risk of complications and mortality, the inadequate access to treatment, the mental and behavioral disorders, the post-traumatic stress disorder, the depression, the substance use, the suicide, the forced displacement. All these are the indirect impact of war. And there is something that we didn't study enough, is the environmental health impact. The contamination of the water, the contamination of the groundwater, the contamination of the air, the contamination of the soil. And then the unexploded artillery, the remnants of war, the heavy metals that are there, the toxic, they call it the toxic legacy that will persist for decades and challenge even the recovery after that. So if we go and speak about when do we consider the health system is resilient? We consider the health system is resilient when it's, despite shocks and chronic stressors, it's still able to perform. It's still able to provide to the people the health service they need on time, in a good quality, and without financial hardship. Without financial hardship. Without financial hardship. I'll say it 3 times because we know what's happening in Sudan now. To describe the health system as resilient, the health system may adapt, which means that with the small resources you have, you are able to deliver the needed service. You can absorb, which is you get some support from SAPA, from humanitarian agencies and so on, and you continue to provide the services to people, or you transform. You change the way you provide the service. And there are many very good examples on how the health system in Sudan has transformed to continue providing the services, what the health workers has done, how did the central warehouses were moved from center to periphery, and how are the non-governmental organizations and all the actors contributing to provide the services in the places where the people are. So the question on what matters, I think you have a center of command. Ideally, it's the Ministry of Health at national and subnational level, which could be the state Ministry of Health or localities. And you need first those entities to have the knowledge, to have the ability, and I'll speak about 4 resilience capacities. One is the knowledge, the ability to get all this information to know where the people who are in need are, and you provide the needed services. Yeah? And this will come with responsibilities of donors. If donors have money, they need to invest in bringing back the health information system. That will help the Ministry of Health build that knowledge capacity. The second one, as Dr. Naima elaborated, is anticipating and managing uncertainty. We know there will be cholera, we know there will be dengue, so there needs to be a capacity to anticipate and cope and prepare for the future shocks that if they come on top of what we are doing, we will collapse. And for this, you have your stockpile of essential medicine, you have your backup plan for the supply chain, You have your early warning system and surveillance, and you use that to decide and to have a decision to protect your people. The third one is managing the interdependence. If I look at the health cluster, the number varies more than 50 actors. The health cluster is chaired or co-chaired by the WHO and the Ministry of Health. But there is a need that the authorities at federal and local level are able to coordinate the health actors to help in prioritizing the resources and also create an inclusive coordination forums. And national authority need to be accountable. We don't have a parliament where we go report back the progress on health. We don't have that regular reporting back to the people. What we spent, what we did, accountability is core. And the last one that's linked to trust, and as Dr. Naima has rightly said, the legitimacy, the capacity to govern the health system, the capacity to build the public trust. This is crucial at time of crisis. And for national authority to regain the legitimacy, they need to engage with communities, they need to engage with local stakeholders, they need to really have people-centered approach to the design of the response. They need to protect the volunteer workers during provision of these voluntary services. And fostering trust in the health system would both encourage the actors, our partners, to invest through the health system, but also ensure that the services reach the people we are to serve. So the role of the partners, I would say, is to take a pro-resilience approach after we do our homework of building those 4 capacities. Then we expect all partners to have a pro-resilience approach, invest in the national system, align the support behind the One Health plan, strengthen the public financial management and go through the national system, and also definitely support, protect, and meaningfully include the civil society and communities in the response. So I'll pause here. I didn't speak about the paper. I think people can Google it.
Thank you. Thank you so much. Thank you so much. And I think we are getting a better scoping of what to be done, because from what Dr. Muntasir Anmar has presented, and then the overall frame that was shared by Dr. Naima, we really need to go into practical steps. That's to say, the measurement, what indicators, the monitoring, and to align with the priorities. But so thank you, Dr. Maysoon. And this actually takes me to my next question. And I have a very dear friend with us today, Dr. Salim Abdurrahman Salim. He is a public health physician specialist and expert in epidemic response and health system strengthening. He worked for the WHO in Sudan and the region, EMRO, and he served also as the director of the Federal Epidemiology Directorate in Sudan, Minister of Health. Dr. Salim has his epidemiology degree from the University of London, and I think now he's a member of the Emergency Health Committee that is working on Sudan National Health Strategy 2030. So, Dr. Salim, one of the impacts of this war is the displacement of millions of families, as our colleagues just mentioned. And many of them had to leave their hometowns or villages. And many of them, they crossed borders to other countries as well. So when we talk about service delivery and healthcare, how do you see the access to this healthcare and health services for those who are displaced, whether inside Sudan or refugee to outside the country. And what priority governance and coordination measures that are needed to ensure access to this service. Yes, Dr. Salim, please.
Assalamu alaikum. Thank you very much for having me on this really very prestigious panel. It is difficult for me really to speak after Dr. Naima, the one who actually I worked with and I honor and parish, and also with my colleagues, and precisely Dr. Muntasir. And I thank him for his leadership during this very difficult years of acute emergency of different layers. Now, it's really also relieving me from, again, describing the situation, because this has been done in very details. But I want to emphasize that all what we have discussed and we have recommended, from Maysoon to Anmar to Dr. Naima and Dr. Muntasir, need to be galvanized within a framework which has been tested, known, and practiced. And this is the humanitarian development peace nexus. Now, why I'm saying this? Because it almost covers all the areas which has been discussed and the actions that has been recommended. The problem that we are facing is the transition between what should be done and how can we do it. This is the gap, and this is where the nexus can really play a very good guide for us to go forward. And as you know, that the nexus has got 3 dimensions: the humanitarian response, the development strategy, and the peace through health. But when we are talking about the humanitarian response, then we should be talking about mainly the problem of more than 13 million displaced people. This is the population of a country of its own. Yani now they are in the move, and 3 million of them are outside Sudan, 11 million are inside Sudan, and so on. So how we can go around this? First of all, when we are talking about the acute phase, which Muntasir well said that it has started in 2023, and it's still continuing because there is a progression of conflict and the instability of the political situation, which are Darfur, for instance, is still under very serious crisis, while there are other states which are stable. They haven't seen the conflict, and they are receiving those migrants coming to them. Now, how can we go through this? And this is definitely by enhancing and integrating access to all essential humanitarian health services. It has to be available. Also, as Dr. Naima mentions, to expand and support community-based health delivery models in IDP settings, border points, civilian evacuation corridors. This is when it happens, and refugee transit locations to support both life-saving care and system resilience. To start urgent environmental health measures, including vector control, water safety, forensic handling of bodies, and clearance of unexploded ordnance in hosting communities, and eventually in the areas of origin when the people are returning. Ensuring protection of health facilities, as well said by Dr. Naima and Maysoon, re-establish and strengthening the cross-border referral pathways and emergency protocols for Sudanese refugees in neighbor countries. And this is very critical, because now we have the shift of the population to the neighboring countries is putting a burden on their system. Countries like Ethiopia, like Uganda and Kenya, and eventually also in Egypt, they have this burden, and we need really to address this and to find a way of how we can accommodate those refugees. From the development strategy and side, and rebuilding the health systems inclusively and equitably, We need to actually strengthen the existing mechanisms that the ministry has already developed, like the Federal Migrants Health Desk, as a central governance mechanism to ensure migrants' health is fully integrated within national government and UN-led relief efforts, rather than managing it as a parallel system. Direct health system recovery investments to serve both displaced and migrants and host populations, strengthening health information system and multi-sectoral surveillance to enable early detection of epidemics, joint assessments, shared data, and collective outcomes across the humanitarian development nexus as a whole, prioritizing the long-term capacity building in health workforce, supply chains, and infrastructures. Now, the last one dimension of the nexus, which usually is missed or undermined and not addressed properly, is the peace building through health. And Dr. Naima, honestly, she was, to be honest, a guide for all of us in this aspect. Okay, and I really would like to perish her efforts when I was working with her then. Now, through this, we need to enhance peace as and stability. It is a paramount to positive essential health services and critical supplies as central components for the forthcoming peace agreements, which we see it in the horizon. It is coming. So we need to make sure that impartial, safe, and continuous access to care that will prepare the population for a better settlement and reintegration. Expand the community-based health interventions and engagements platforms, and also to institute the peace-sensitive planning within coordination structure, emphasis, local leadership, and conflict-sensitive programming, and adaptive mechanisms, and also support which will be supported through flexible financing alignment and mechanisms. Strengthening the regional health cooperation by formalizing cross-border health agreements for Sudanese refugees that protect equity in access to care and to ease pressure on the host countries, while enabling planning for supported voluntary returns. To accelerate and to rehabilitate the migrants' areas of origin by restoring safety, essential infrastructures, critical services to facilitate dignity, has dignity for the population when they go to them, and obviously this return has to be voluntarily. In conclusion, if we adhere to the humanitarian development peace nexus approach, we transform our response from fragmented crisis management into a coherent and integrated strategy. Nonetheless, empowering the Sudan Federal Ministry of Health, aligning mechanisms with partners, strengthening the regional health access arrangements for refugees and displaced, and building resilient systems are not optional, they are imperative. Eventually, through operationalizing the nexus, we can protect lives today, rebuild stronger system for tomorrow, and contribute to greater stability across the region. Thank you very much.
Thank you, Dr. Salim. And I think this is smart to link the need and the situation in Sudan with the HDP nexus. And for this, I promise we will invite Dr. Amuna from Oxford to one of our coming webinars. I think she did an excellent work, whether in Africa or other countries as well. So I mean to have this question, not to forget our people who live outside Sudan. And many of them, actually, they are living in conditions that might be even more tough than those who are inside the country. We have to always remember them. And I just shared with you in the chat box the report released by Yale about the mass killing. It was published October 27. I shared it with all of you. And also would like to welcome Dr. Muhammad. And I know that you are in the middle of an ongoing event, but appreciate your presence. I will come back to you in few minutes, but I just want to, we have many questions in the queue, and I have also my own list, but there is a burning question, and I invite all our speakers to respond to it in 1 or 2 minutes, please. Is that in Sudan now there are areas that are considered as stable states, as well as areas with ongoing fighting and violence. How can the system there in Sudan, let me be more specific, the Ministry of Health, run two parallel systems that is fighting and responding to ongoing needs, and a system that considering the recovery and rebuilding development priorities. So if I may start with Dr. Muntasir, please.
Thank you very much. Thanks a lot. I heard Dr. Anmar, Dr. Naima, and Dr. Maysoon, and Dr. Salim. These are very rich thoughts and advices for us to guide for the future planning and implementation, and also to cover the real situation with the filling gaps in most of the areas. For us, we used to have limited area with stability, and in this area we moved. The Ministry of Health from the start decentralized the work in 3 stations to be flexible in movement and also in availing all the resources and availing the essential health services for all Sudanese. As mentioned from the start, that the Ministry of Health is not only for the stable areas or states. So we moved to work with all the health cadre at even the states that in the conflict situation nowadays, like in Darfur. So bringing them with us and availing the essential needs like vaccines, response activities, coordinating with the health cluster partners. This was and is still part of our responsibility as Ministry of Health. For the stable areas, I think, although the war affected us negatively, but some of these came positive for some states, like the states, the periphery states like Northern State, Red Sea, Kassala, that they improve their health system through availing some specialties like GIT, radiology, cardiology, and even availing some of the diagnostic centers, including MRI for diagnostic, and also CT scan. Are you?
Yes.
Is it clear?
I think
so.
Yes. Thank you.
Decentralization, moving from availing centralize the stocks, the human resource, and even the equipments in one area to most of the areas at the state level. These are part of.
Keyword is decentralization. Yes, and I can imagine how demanding working in 2 different systems or demand. And Mark, in 1 minute, what is your
Yeah,
responsibility?
this is why I always like say, the aspects of investing in local communities is the bridge, to reach like every Sudanese people currently on Sudanese land or even in nearby countries. At the end, the responsibility of the health of every Sudanese is actually the government responsibility. So we need to reach all, and I'll like some sort of substituting the old approach of utilizing community as only mobilizers or like informants to be part of the table is very important. And building on the point that also Dr. Salim like strongly like alluded to, the aspects of utilizing the humanitarian development and peace nexus, and this is how you will help the peace feasibility, if you get my point, in terms of actively put the communities on the table, ensure they have like a clear role in your strategic plans, and also like on the implementation of these strategic plans operationally, give them the power in terms of flexible financing, because at the end, they're going to use small, fast, and predictable grants, by the way, even for the Ministry of Health itself, not only for international actors or like local organizations or like diaspora-led organizations or any actors currently supporting on the ground. And the last element is actually providing, the technical accompaniment, let's say, not the substitution, because at the end, they can be like a wheel for the Ministry of Health to reach, the people wherever they are. Just supporting those like local cadres in terms of providing protocols, for example, mentorships, gonna extensively support you to eradicate the aspects of psychosocial first aid support, like as Dr. Naima just like talked about earlier, which is very important element, the outbreaks preparedness and response, other elements linked to the aspects of community mobilization for protection as well, for the gender-based violence and other elements of protection. So yeah, investing in communities is the best way to reach people in hard to reach areas. Thank you so much, Dr. Haitham.
Thank you, Anmar. Keywords: peace, community, and preparedness, as well as mentioned by other one, the decentralization. So, Dr. Naima and Maysoon, in keywords, 30 seconds. Dr. Naima, then Maysoon. Please unmute your mic, Dr. Naima. It's still muted.
Maysoon can go before me.
Yeah, please, Maysoon.
Okay, so I think there are responsibilities of the Ministry of Health and the government, and there are responsibilities of us actors who are supporting that response. There need to be efficiency in the response. There need to be one plan, one master plan. We need you in the steering role. We need you in at the head of that response. From our collective part, I think the agency and capacity. Agency of the Ministry of Health is the plan. Agency of the communities is participation in decision making. We need to invest in the capacity, the 4 resilience capacities. Accountability is core. Accountability to the people, accountability within the government, and accountability of the donors to the government and to the actors. And the last one, transform the operating model from input-based to different financing model, as Anmar has rightly said. And the most critical intervention is to stop war.
Thank you. Thank you so much.
Yeah.
Dr. Naima.
Okay,
now
thank you,
20 seconds.
Thank you. I started with peace, care, and compassion, and I want to give a very clear message. Health security in any nation is regional and international security. The core constitution of WHO says is the responsibility of the individuals and states. I add individuals, families, communities, private, civil, NGOs, and states. So this is what I have been trying to bring to the table. Let's shift the normal, traditional approach that we know. It is time. Do not think of ministries. It is time to put the people at the center. That was my success in Iraq, and it was for my friend Salem. It's actually the health, peace, development nexus. It came from Iraq, but we called it emergency, rehabilitation, recovery, development, and peace, purposely, because rehabilitation and recovery takes time. So I would like to bring this message, definitely with lens of equity, and then you can bring everybody, women, disabled, displaced, refugees, right? And I am a person who says, let's believe in human being and do not categorize. That's where I come from. Let's not say yellow color, blue eyes. No, it's every human being. This way we are going to succeed. And Sudan, Allah ma'akum. Dr. Muhannad, welcome. It's not only Sudan, we have a challenge. And please, resilience does not mean we should separate between what is already peaceful and what is not peaceful. Anything can erupt anything. So let's be investing in people. Thank you.
Thank you. Thank you. Well said. And before listening to Dr. Muhannad, Salim, one closing sentence.
Well, thank you very much. When in one sentence, peace is coming. It is coming. It is on the horizon. Khalas, we can see it. It's coming. Now we need to be practical, stick to a framework that is well organized, tested, known. Let us work within it. It has got good evaluation framework. It contributes and integrates all what we have mentioned today, and bring in the expertise. I believe it is time to advocate, and Sudan now is in the international agenda. Let us take this opportunity. It is really a very good opportunity. Sudan is on the table, and let us push to be prepared when the money is coming, when the people is coming. Then we need to have a well-organized framework, which is the nexus. The nexus again. Thank you very much.
Thank you all. And I would like to conclude this webinar by inviting Dr. Muhannad. I will not introduce him. Just Muhannad. Mansour is of course, the executive director of EMFNet, but also well known of his strong standing with Sudan case since the start of this war, and even years before. Dr. Muhannad,
thank you very much.
Question, and how do you see our situation in Sudan, and why the world international community doesn't?
Sudan is always a great country. Sudan always a great country. This is, friction, and I am sure Sudanese will pass this, and it will be part of their moments. But thank you very much, and allow me first to extend my sincere thanks to our distinguished, respectful speakers and moderators, for their insights and contribution. And really, my appreciation goes to all attendees who joined us today, because their engagement and your engagement and the presence are what gave these discussions their true impact. And if you allow me just few sentences, although we are talking a lot about community engagement, about the power of the Sudanese public health people and others, but we also need to highlight the international community failure to uphold its commitments towards Sudan forgotten crisis. We should not hide this, and we have to put things on its place, that the international community did not do good towards Sudan, and we expected, and we still expecting to do much more in such a critical crisis over the world. So yes, as Dr. Naima said, we need to depend on ourselves, but we need also the international community to take their responsibilities and their roles towards Sudan. And, this is, Sudan has not received the level of attention resources or coordinated action similar crises in other regions. And this is very important, critical. I know that this is critical, but we have to highlight it. The global response has been fragmented, slow, insufficient, leaving millions without the aid that they urgently needed. And this is fact, and this is recorded, and this is published in different places. Second, I would like to stress the urgent need for democratize humanitarian assistance and access to healthcare. Underscore the life-saving aid must not be constrained by any political deviations or bureaucratic restriction or shifting geographical or geopolitical interests. And we see this. And we have to come over these internal challenges and to be neutral and imperative to protect civilian life, ensuring that communities in conflict-affected areas can receive essential services without any obstruction, without any challenges, and without any geopolitical situation. And finally, I would like also reaffirm it's not Muhammad, it's infinite commitment to Sudan and to working with partners to advocate and for greater support. Affirm that Infinite remains fully keen and loyal to supporting Sudan public health needs through operational engagement, technical assistance, capacity building, and the other things. And I would like to stress that Infinite will continue collaborating with the regional and international partners to amplify Sudanese voice, mobilize more attention and resources, and push more coordination mechanisms. We really believe in Sudan always, before the crisis and during the crisis and after the crisis, inshallah. So thank you, and thank you all for allowing me, this few words to say. Thank you very much. Over to you, Aitan.
Thank you, Dr. Muhammad. And as you said, we at Infinite always with Sudan and its people, and I think this is one of the most enjoyable discussions regarding the situation in Sudan with this elite group of speakers and panelists. I would like to extend my sincere thanks to Dr. Muntasir, Dr. Naima, Dr. Maysoon, Dr. Anmar, Dr. Salim, Dr. Muhammad, and I will do my best to share the unanswered question, the Q&A, with our speakers, and we will generate a report out of this webinar that can be widely disseminated. So to this end, thank you, our guests and audience, and see you in our coming webinars. Thank you. Have a nice day.
Thank you.
Thank you very much. Thank you very much. الله يديكم العافية. شكرا لكم كثيرا.
شكرا لكم جزيلا. Thank you very much. شكرا لدكتور مهند وشكرا لدكتور هيثم. شكرا لكم كثير.
Thank you.